resistance. So the bigger that gap, the more resistance our patient has, the more resistance the breath had to overcome to get that breath into the lungs. And the difference between our plateau pressure and that baseline, or the PEEP, is determined by the amount of tidal volume set and your patient's compliance. In these graphics, we're looking at a volume-oriented mode. So note that in the pink picture on the right, on the left side of the picture where you've got the word PEEP, notice that it's at a certain level. If you followed that along, you can see that as the breath returned to baseline, it did kind of return to that PEEP level. But then you can also see a little rise there as the scalar tends to go off the screen, where it's trapping a little bit of gas and creating some auto PEEP.
Thanks, Shauna. This is Jen now. Now I want to talk about some influencing factors of how and why we choose specific ventilatory modes, depending on what the patient needs. And what affects this is the patient's gas exchange. Gas is exchanged between the alveoli and the pulmonary capillaries via diffusion. Gas molecules move from an area of high concentration to an area of low concentration. PO2 is lower in the alveoli and compared to the external environment, which allows for diffusion of oxygen into the alveoli. PCO2, in opposition, is higher in the capillaries than in the alveoli, which allows for diffusion into the alveoli, where it is exchanged during expiration. So looking at that, that's what helps us determine what kind of mode our patients need. And we look at, are they taking deep enough breaths? Are they taking enough breaths per minute? What is their alveolar ventilation? Do they have enough minute or total ventilation? And what kind of dead space do we have? All these things have an influencing factor of where we set our ventilation.